organization I work for created a group called ESTEL, which stands for Essential Standards to Enable Learning. And this is an enabling organization for the learning health community that Josh and Chuck Friedman run out of the University of Michigan. As we got to work on this group, what we had hoped to do was to recommend and adopt standards that help to create the capabilities of the learning health system. We sort of had an insight this past fall in a meeting that we were maybe a little bit ahead of ourselves in trying to select standards, and we then sort of changed our focus to structures to think a little bit more fundamentally about the learning health system and the technology that would support it. This slide shows a representation of the learning cycle or a learning loop. Up in the upper left-hand corner, you see a representation of a learning cycle from Chuck Friedman's slides. This is a conceptual representation that shows how there's a decision to study a particular subject. There's an assembly of data, analysis of data, and interpretation. And this then is taken into some sort of action step that goes back into the actual healthcare system. The arrow points to the next version of this, which a group of us working on the ESTEL project came up with last September. Essentially what we're looking at, there's a reality, there's a representation of that reality. That representation creates knowledge, and the knowledge goes back into the system of learning. And then finally, in the lower left-hand corner, you see what we consider to be a structure for looking at a learning cycle, a learning loop that really kind of tells us what are the technical steps that have to be done to automate a learning loop like this. So there are 5 steps here. The first step is really to start with the healthcare providers and the mechanisms that they use to create raw data. And then the second step is taking that raw data and somehow aggregating it or transforming it so that we now have an analytic data set, which is analyzed in step 3, creating an inference, which is then packaged into some sort of a guidance. And that guidance then returns to the healthcare setting and informs the actual care process. I'm going to briefly step through those 5 steps in separate slides, talk about them from the perspective of a technical implementation, and then we'll look at a subsequent time, this will be the step-off point for identifying the standards that will be necessary to enable these steps. So sort of obvious, I guess, but the first step of creating the raw data is the foundation of all subsequent activities. And the main player in this first step of creating the first representation of healthcare is typically done in a first-order data capture system. An electronic health record would be the _1 application in that regard. There are also personal health record systems where patients enter data on themselves. In the research world, there are electronic data capture systems which capture data specific to research. All of these create first-order data representations, which we're calling here raw data. The second step in the learning cycle is aggregating and transforming these data. This is a type of work that I've been particularly involved with in my role at CDISC. It's the role whereby data are extracted from the first-order system, the electronic health record, primarily, and repurposed, if you will, for some sort of analysis, some sort of beginning of a learning step. There's a number of standards that we've worked with on this, and again, I'm not going to get into specific standards, but this is a step where a lot of work has been done by HL7, CDISC, and Integrating the Healthcare Enterprise, IHE. The third step, producing data sets, analysis data sets that then enable inferences to be drawn. In the research world, this is the purview of biostatisticians. Similar work is done in the public health domain. The Centers for Disease Control have a lot of data that they pull out of healthcare settings to analyze the outbreaks and the performance of various types of healthcare organizations. And then we have quality reporting. There are some subtleties to this. The data that come out of the healthcare setting are not necessarily exactly what you would want for this analysis step. So there's often a sort of reinterpretation step that's involved in that as well. The fourth step in the automating the learning loop is taking the inferences that are generated by this analysis of data and to package them up into what we're calling a guidance. As we get down to these step number 4 and step number 5, we're really getting into the aspects of the learning loop or the learning cycle that where the least work has been done. It turns out that in many cases the analysis of data, the knowledge that's acquired through research, public health analysis, exists for a long period of time, maybe a number of years, before that data percolates back into the healthcare setting. So this is really the area where I think there needs to be some concentrated effort. How can we do a better job of not just analyzing data and coming to conclusions, but turning those data into some sort of actionable guidance? And the fifth step then is how do we take these guidances and use them to inform the healthcare delivery? Probably the best way to do this is to allow those guidances to be inserted right into the electronic health record at the point of care, and to make sure that those guidances are triggered at the correct place in the practitioner's workflow, and to present those guidances in a very unobtrusive, concise way that integrates tightly into the workflow of the clinician. Nobody's going to take the time to read a peer-reviewed journal article to find out what to do next when they're prescribing or looking to decide what the best treatment pattern might be for a particular disease. These guidances have to be both rigorous and firmly founded in the correct objective data analysis, but they also have to be presented in such a way that they're actionable and can be worked into the workflow of the healthcare providers. So that was a very quick whirlwind tour of the work of Estelle. The work is ongoing. We are going to take this structure and this breakdown of the learning loop or the learning cycle and begin to identify actual standards. And by standards here we mean standards that are not just a dominant player in the market, but standards that are negotiated in the open standards development process. So that will be our next step, and we'll be furthering the work of Estelle in the next few months. That concludes my remarks. I believe that the next presenter will be Holt Anderson.